Hello, welcome to the Unscripted Pharmacist Podcast. Today we're going to be talking about insulin resistance. What it is, what's the origin, how does it manifest itself in humans, as well as what you can do about it.
This is the Unscripted Pharmacist with Kyle Rootsaert, Doctor of Pharmacy and Board Certified in Advanced Diabetes Management, and Lenora Casey, Oncology Certified Registered Nurse. Because each person is unique, consider this as medical information, not medical advice. See your physician regarding what might be best for you.
All right, here we are once again with Lenora Casey. Awesome.
Hi.
So, insulin resistance.
Insulin resistance, yeah.
Insulin resistance is a huge problem with our world, isn't it?
Yeah, it is. But let's talk about, I'm going to ask you a few questions because this is a topic that, because I'm a cancer person, so this is definitely
we get to cancer
foreign.
eventually,
yeah.
but yeah, that's
but
exciting.
It's kind of a foreign topic. So, insulin resistance, what is insulin? What is it?
Right. I've heard some people tell me, and it almost gets me a little bit angry when people go, you're talking about insulin? We're not talking about diabetes here. I'm like, okay, but every animal cell has insulin receptors. So obviously it involves multiple systems, different tissues, right? So it's going to affect different body types and tissues differently. So there's normal physiological insulin, and then there's pathological insulin. Okay, so you have normal insulin resistance, which is actually, you need it. We wouldn't be the size that we are if we didn't go through puberty and develop our own little insulin resistance to allow ourselves to grow bigger. So our insulin levels were higher when we were adolescents. It also occurs in women. Women, to prepare for childbirth, need to have certain development, right? Insulin resistance is an important part of that. So in order for the baby to grow, insulin resistance that is normal physiological insulin resistance.
Okay.
And then there's pathological, which
And that's the biggie problem.
That's the big one. But you want to know, to what extent is this a problem? It's 2/3 of our population that has this problem. Okay, you can just say one of the manifestations of insulin resistance, and one of the first organs that gets involved is the liver.
Okay.
And we've got 45% of our adult population that has non-alcoholic fatty liver disease, which really is almost non-existent prior to 1980.
Oh, okay.
And then if you want to talk about worldwide, it's 25%. 2 billion people have non-alcoholic fatty liver disease. So you can safely say that 2 billion people have insulin resistance.
And that's what you see first? Is that,
It's probably one of the first things that you do see, but it has so many different, and we'll go over some of this, what does this look like in us? But I would say this is that diseases of Western civilization has pretty much everything to do with our diet, right?
Right.
Insulin and carbohydrate intake, insulin goes up with carbohydrate intake.
Because of the sugar.
Because of the sugar, but because of a high carbohydrate diet, right? Which we've been kind of forced to with this food pyramid. We've been hounding that fat is bad, since the 50s and 60s, and look, this is where it's gotten us.
And then plus the push for the plant diet.
Yes, yeah.
And then rice,
Right, all these things that are higher in
grains.
Carbohydrate, but they're lower in calories.
Right.
And we're supposed to be attracted to that notion of this calories in, calories out, which I feel really changes the blame.
Then we have to talk about good calories and bad calories. That's a whole different subject.
Well, no, it's very, very much related, but.
So we have this insulin.
Yeah, and this is a normal, natural hormone. Every cell in our body has these receptors of insulin.
Okay.
Right? Insulin levels rise when we eat carbohydrates, especially. They do rise with protein, and it's pretty negligible with fats.
Okay.
some proteins elicit a higher insulin response than others, but I really don't know of a whole lot of people that have, insulin resistance due to excess protein intake.
Right. I don't think they've studied that
right.
at all.
We have excess insulin due to lifestyle, right?
Right.
Like if you look at that
awesome
awesome little tree.
The little tree.
The little tree is really fun.
The tree of life.
Yeah, the little tree of life, and we'll include that in
Yeah.
the show notes. But it really kind of talks about like what are the different lifestyles, the different environmental factors
foods
that create the insulin resistance, which drives diseases. Really, I think of modern civilization. Like, why do we have all these problems? Hey guys, it's the food. It's not genetics. We'll talk about genetics a little bit and how that plays into it, but really it's our environment.
It's our food.
Yeah, for sure.
Yeah.
I guess
Go ahead.
I guess it gets kind of complicated to start. Like, okay, what is the origin? Like, what sends this ball rolling? Like, what happens first? I can't really say, like, from an environmental perspective, like what exactly it is, but there's some sort of insult, essentially.
Right.
Lifestyle, whatnot, that causes an excess of fat mass within a cell. We call that hypertrophy.
Right.
So you're born with X number of fat cells.
Okay.
Whether or not they can expand, right?
Which they do say that it does expand in the cell and outside the cell.
Right. So these fat cells, really what it comes down to is, like, what's your fat tolerance? White people, Caucasians, have a much higher fat tolerance. We can handle a lot more fat, cell-wise, than other people, right? Other races. So, yay, Caucasians, go ahead and hoop it up, right? So, you've got this excess. When you're born, you have X number of fat cells, right? And so when they expand, they can expand to the point that they become hypoxic.
Okay.
So in other words, they don't have the oxygen that they need.
Okay, so then what happens when they become so hypoxic that...
Then they start becoming inflamed, and this creates this whole immune response. But if you think about the contents of a cell, when a cell is its normal size and that fat droplet is rather small, mitochondria can move around. Other organelles can do their proper function, right? But what if now you've got mitochondria that are having difficulties because of the size of the cell, oxygen, insults like sugar, right? You've got an excess amount of basically calories and energy coming in, and that mitochondria is being stressed.
Okay.
So the mitochondria is trying to keep up with this tons of food that you're sending it its way, and it can't keep up.
So then I think people would probably ask, okay, what is mitochondria and what does it actually do?
Yeah, that's a good question. Okay, so mitochondria generates energy.
Okay. And that's basically...
That's life.
And they used to call it the powerhouse of the cell.
Yeah, the powerhouse, that's a good way to define it. Creates ATP.
Oh, yes.
But when it creates ATP, it generates something called reactive oxygen species, ROS.
Okay.
ROS is normal.
Okay.
But when we increase the ROS too much, mitochondria start failing.
Okay.
So now you've got, and it's exhaust.
Right, and so now people become fatigued. Is that kind of what happens?
Fatigued, you're tired, and then things don't start working properly in the cell.
Okay.
Like normally, under the right circumstances, insulin, going back to insulin now, insulin would take glucose and put it into the cell, allow through a kind of a lock and key mechanism.
Right. Like the insulin is the key that unlocks the little portal that then the glucose can then travel down to the cell.
It goes, it creates, there's multiple steps. Nothing is super easy.
No, there's a million, there's a lot of steps.
Super difficult.
But I was making it super easy because people don't need to know all of those steps.
There's tons of steps involved
there. Downstream, upstream.
Right.
Yeah.
But with multiple steps.
Yes.
There's multiple ways that things can get messed up. Right? So like, okay, there's a lot of things that are going on here. How much of this is genetic? Probably not a heck of a lot.
Not a lot, they were saying. That wasn't a lot that has to deal with our genetics. It has to deal with everything that we're eating because of the glucose.
I would say genetically, it probably has more to do with fat tolerance. How big can your fat cells get before they become problematic, before they start leaking, before insulin can't do its job anymore, which would be to store energy, right?
Which is the fat.
And inhibit lipolysis. So lipo meaning fat, lysis meaning breakdown.
Right.
So normally, under normal circumstances, insulin inhibits that. So you have fat storage versus fat breakdown.
And that happens, I think, what they were trying to talk about was how the insulin levels will go up. There's so much glucose in the cell already, and the insulin just can't, like the cell's like, no more, stops the lock and key mechanisms. Right. Then the glucose starts building outside the cell, and then the glucose actually in the cell starts becoming fat. Right.
You've got how much can that fat cell expand before it dies? It is trying to protect itself. So when it's trying to protect itself, you make less insulin receptors. You have this down regulation. Hey, insulin, you can't keep doing this to me, right? Says the fat cell. Says, hey, if you keep doing this to me, I will burst. I'm going to protect myself. I'm going to develop my own insulin resistance here, and we're not going to respond to insulin like we used to.
Okay.
As a mechanism of survival for the adipose, the fat tissue.
Right, and that makes sense.
Right. So now what happens when insulin doesn't put the brakes on lipolysis, fat breakdown, you then have the opposite. So now fat is being broken down and it's going into the bloodstream. So what do we get? We get free fatty acids in the bloodstream now.
Okay.
So now we've got more fat circulating in the bloodstream as a direct result of the insulin resistance that is really the fat cell trying to protect itself and its mitochondria.
Okay.
It wants to protect the mitochondria, and the mitochondria is going, hey, too much. There are mechanisms that the fat cell can do in order to try to keep it going, but what happens is the fat cell is going to oftentimes expand beyond its borders, becomes hypoxic. When something becomes hypoxic, it starts to die.
Right.
It starts leaking these inflammatory mediators, which says, hey, I need help. And the only way the body can do this, it doesn't scream out, I need help. It starts releasing cytokines, adipokines, inflammatory mediators. So we were talking about, like, what can we do early stages was like, hey, we could start measuring inflammatory markers. These people with problems with insulin resistance also have a lot of inflammatory mediators that are elevated. We could be getting that earlier. We could be measuring insulin as well.
So then what test is that? What they?
Oh, you would measure, it would be expensive. TNF alpha, IL-6, all your cytokines. Like, there's a lot of mediators that say, hey, cell, we're dying here. I need help. Go recruit some help. The immune system is then on high alert. And it goes, all right, let's go get some white blood cells. Let's go get some monocytes and macrophages, and we'll get them in here. And they will clean this up, hopefully, and repair things. That's part of the normal process, as kind of the part of the process of apoptosis, which you're familiar, which is cell death.
Right, cell death.
When cell death comes, you've got all kinds of inflammation, all kinds of inflammatory mediators, right?
Yes.
That happens in a fat cell. That is probably what then drives the next step, which is fatty liver. Now the liver has all these inflammatory mediators, and it has to deal with them. So then the liver then becomes basically infected. Fat cells first, liver second, muscles kind of along for the ride as well.
Right. Okay. Well, I mean, there is muscles. The muscle cells actually have fat within the cell.
Right. But normally when you eat some food, the skeletal muscle picks up like 80% of all that glucose that you just ate and just whoosh, just sucks it up, right? Normally.
Normally, yes.
Normally. But if it has insulin resistance, where is all that glucose going to go?
In your bloodstream.
Body has to deal with it. In your bloodstream, but how is your body going to deal with massive amounts of glucose in the bloodstream, right? you've got massive amounts of free fatty acids floating around. That's got to go somewhere, right? I'm thinking liver. I'm thinking going in the skeletal muscle, right? It's going to have to be dealt with. So I remember there was the American Diabetes Association has this CDCS exam, and I remember getting to this one question, which is like, it is beyond, there's robust evidence to say that it is free fatty acid that causes type 2 diabetes. You missed the big part, which is why is those free fatty acids in the first place elevated, right? It has to do with the fat cell and insulin resistance at the fat cell level. But I was just floored. I was like, I can't do this. You're telling me that saturated fat from the food is what's causing. You got it wrong. It's free fatty acids from cells that are leaking. That's really driving type 2 diabetes.
Okay.
But everything that we're talking about, you may never have elevated glucose at all. You may never become diabetic. This isn't about diabetes.
No.
And that's, I think, is the message
I mean,
we need to get
there is some
across.
component to type 2 diabetes, of course. That's why we're talking about insulin
Yeah.
resistance, because it is somewhat type 2, but diabetes that we're now looking at,
Right.
especially with the population that we have.
I think that is such a small, what the number one killer, cardiovascular disease, is really diabetes in situ. That's insulin resistance. That's what's driving cardiovascular
But they
disease.
do talk about, I mean, okay, so with insulin resistance, what diseases are now we looking at?
Lots.
Yeah?
It was huge.
It's your tree, right?
It's the lovely little tree. I
was
also
like,
have
oh,
a ginger
oh my
man
God.
too. But
yeah, I like the ginger man.
yeah.
But, I mean, it was talking about, like it causes...
Cardiovascular disease.
Well, I mean, you said
A huge part.
fatty
Heart
liver,
disease, right.
stroke because of, all the other cascades.
I think
Heart
these are fascinating to
disease,
go into the mechanism of some of these.
PCOS
Yes.
especially,
Polycystic ovarian
inflammation,
syndrome, right.
diabetes,
Infertility.
and then obesity. But, okay, so then we have all these diseases that are related, but what signs can people look for that possibly they're insulin resistance? Like, I know that there's some signs.
For
like-
sure. Some of it's lab, some of it is just physical manifestations. So I love this topic, by the way, because I can go to Walmart and go, everybody that's got it, right? but to talk about just obesity isn't, there are people that can be obese and very healthy. Because we're going to talk about different types of fat. We have
Right.
visceral adiposity, which
Right.
centralized adiposity, where you've got fat in the belly section. This is probably the most common and obvious signal that there's something's wrong.
Yeah, your waist size, and I think
Waist
that's something
size.
that they talk about.
Yeah, so I can't remember the numbers. I think it's
It's like for women,
Waist
I think
circumference
it's 35 inches for women
and 40 for men.
Uh-huh.
Yeah. And so when you start measuring this versus there's subcutaneous fat. Let's just be totally honest here. You can have tons of subcutaneous fat and be totally fine and totally healthy and it never cause you a problem. Matter of fact, it may be actually protective because now you've got places to put things. Okay? Kind of like muscles to glucose.
Okay.
Right? The bigger the muscles, the more that you can pack it with glucose.
But what's the bad kind of, I mean, isn't it
Yes.
the visceral?
Visceral adiposity, visceral, like basically you got central obesity where you got it in the belly section, which is highly vascularized, metabolically active. It is a lot more metabolically active than subcutaneous. So it's basically fat that's surrounding your organs and your intestines,
And
kind of
those are
acting as
that's
padding.
the bad kind of. Well,
That is the bad kind.
Yeah.
Yes, omentum fat. So it's fat cells that have continued to expand. But normally, you wouldn't have much fat there anyways, right?
Right.
You'd
Well,
have,
you're not supposed to.
Right, but it's basically there to pad organs,
Oh.
and so, hey, we got a place to put it. But this is the determinant. How healthy are those fat cells? Some races are able to make smaller little fat cells. Asians, on the other hand, don't have that ability to make a whole bunch of fat cells. We call that hyperplasia. So they have fewer fat cells,
Okay.
and they don't reproduce more. So they are limited. Their
Oh.
tolerance is very much limited. So
Okay.
they develop diabetes at a lower BMI, lower body weight, right?
And that's body mass index.
Yeah, body mass index, right. So the different manifestations, non-alcoholic fatty liver disease is really common, obviously. It may not be that obvious other than just kind of this low-grade inflammation, or you'd have to measure some stuff. You'd have to...
Right, you'd have to get, I think, isn't it an ultrasound or?
Yeah, but you can do a little test. You can put your back up against the wall, put your feet out in front of you, and can you see the tops of your toes? Basically, if you can't look over your belly, obviously, then you would have more fat in a dangerous place than you really want.
Okay.
Common with men, unfortunately. Women, you kind of have the ability to make more subcutaneous fat via estrogen. So that's kind of nice.
Oh, yeah, that is nice.
Yeah, and
Until
you-
we stop making estrogen.
Until you stop it. Yes, exactly. And that's why I'm a huge proponent of using, bioidenticals and estrogen replacement therapy.
That's a whole nother
I
issue.
know. You love doing that.
No, but I mean, we have to be careful because, and then we're going into the cancer realm.
Yeah,
Because of genetics, and you're going to add hormones, which hormones should have stopped,
Right.
and then you
Right.
might have other issues later.
So how long are we supposed to live?
Well, it would be nice not to have breast cancer.
Yeah.
Yeah, so.
Yeah, that would be. But
Because
what
that's
drives
hormone
that?
replacement therapy, and they're finding that maybe that's not true now.
Yeah.
So I think
everywhere that I've looked, I've seen breast cancer
Right.
on the list of
It is.
metabolic syndrome,
Yeah, yeah,
insulin resistance.
yes,
When we talk about metabolic syndrome, we're talking about insulin
we do.
resistance.
And and then, of course, with insulin resistance, especially
Yeah.
with obesity, we worry about cancer,
Right.
and then we worry, as we
And I would
lose
say,
our
and I
hormone,
would
hormone
respond with
abilities.
prostate cancer as
Yeah,
well.
I mean, it's a hormone-driven thing.
Yeah.
So just like metabolic syndrome, hormone-driven, we have breast cancer, we
Right.
have ovarian, we have prostate.
Yeah. These are all pathological signs of hyperinsulinemia, too much insulin, insulin resistance. Before we go back to it, I wanted to come up with some analogies that would help people understand kind of what insulin resistance is.
Oh, that's good.
So, so some of them was, there's an Uber driver, right? Okay, so
Okay.
imagine you're downtown Sacramento, and you got to get, I don't know, you're doing something, right? You're going to some sort of event, okay, in downtown. So you get in your Uber driver, you get there, drops you off, and then it's the game's over, the event's over, and now you need an Uber driver. And there's a whole bunch of you. That's like glucose, and there's only so many Uber drivers, right? So you're gonna pack it in, right? You're gonna take that glucose and you're gonna try to use as many Uber drivers as possible, and then try to deal with this massive amount, say, of glucose. You need a lot of Uber drivers, a lot of insulin to put this away. Okay.
Okay.
So imagine that you got more and more and more Uber drivers to be able to transport these people, right? But the problem lies with, can you handle it with the amount of Uber drivers that you have? I wouldn't say that nowhere in the description of type 2 diabetes would I ever agree with the fact that you don't make enough insulin.
Yeah,
And that is what
the
I thought for
studies are
so
showing
long,
That
so long,
insulin
yes.
is being overproduced,
It's right, and
it's the block at
but
the
for
cell.
so long, and so many people and so many physicians will say, no, you need insulin because you don't make enough. And I'm saying, no, you have type 2 diabetes, and by definition, that's too much insulin. Your insulin levels are super high, they're super therapeutic.
Yeah, but for
massive-
some people whose glucoses are really high at 600, 400.
They still make a ton of
Yes.
insulin.
But for some reason, like the insulin helps also drive those numbers.
Well, we're
down.
overwhelming that resistance.
Yeah, okay.
Overwhelming it. And now
And
we're
some people
putting
do
that
need
away.
that. I know.
But
okay,
so
some people do.
right.
That's
Yeah,
where I
this
come
gets
in
me
because-
totally worked up because
yeah.
I think, hey, type 2 diabetes is too much insulin. I'm saying insulin's toxic.
Yes, but
More
there are
toxic
some-
than that glucose. Yes, in the hospital in an acute situation,
Yeah.
we were going to
Well,
give
even at
insulin
home,
for sure.
when patients come and have their labs drawn,
Mm-hmm.
you know, we're also giving them steroids, which
Oh,
increases
for sure.
their
Yeah,
blood
yeah.
sugars. And then all of a sudden we get a call, their glucose is 600.
Yeah.
Oh, well,
Yeah.
hopefully they have insulin at home. You know, call them what kind of insulin.
Right.
Yes, they have sliding scales. Yes, they have that ability.
Right.
But it does also work.
Yeah, you're still, once again, you're overwhelming that insulin resistance and
So you're
becoming,
just pushing all that extra insulin in to
Yeah.
make the body deal with what that
Right.
extra glucose.
That's all we do in the
Okay.
hospital. We overwhelm their insulin resistance. We give them more Uber drivers,
Okay.
right?
Yes.
And we put it away. We deal with it that way. But
It's
this
not
is,
the ideal
Oh, it's
situation,
definitely
but
not.
it definitely, you don't want high blood sugar.
right, but I would say glucose toxicity
Mm-hmm.
versus insulin toxicity. I think the insulin toxicity should be the focus.
Right.
We should be going, hey, let's get you off of the insulin. Let's reverse that insulin resistance.
Mm-hmm.
Let's let insulin work better.
Right.
Now you've got less Uber drivers
Mm-hmm.
and more passengers that you're able to tolerate,
Okay.
right? Or the other, my wife likes this one, it's the alarm fatigue of the Freestyle Libre 2, the CGM that has these alarms that go
I
off.
know.
At first you're like, oh my gosh, what's that? You know, freaking out, right? But after a while you're like,
You shut off the
nah.
alarm.
You shut off the alarm, right? Or you just don't even, you don't even recognize it anymore.
No.
It's not even there.
Well,
because,
it's hard to,
yeah,
like, your
you,
phone's going off constantly.
you're totally fatigued. You're like,
Well, it's alarm fatigue. And they talk about that with nurses. We get alarm fatigue. 'cause
so
those
many alarms.
going
Tons.
off. Yeah.
Tons. Here's another analogy. So imagine, this is probably a little bit more scientific, but imagine that you took in, say, 60 grams of carbohydrates, 4 slices of bread, you had a large Subway foot long, right? You got 60 grams of carbs that are going in. Your blood sugar goes from 100 to 200, which
Mm-hmm.
is what someone would expect. But you took in 60 grams, and I'm only seeing on my graph 5 grams. Where's the other 55? It had to be dealt with, and it had to be dealt with immediately, very quickly. So that pancreas went whoosh, released a ton of insulin that was stored, as well as just making it like crazy. Okay?
So it's already making insulin, so when you eat the 60 grams, it pushes extra.
So 5 I can see. The other 55 had to be dealt with.
So 5 you see with the glucose spike.
with the glucose spike
Okay.
when I go from 100 to 200.
Okay.
Okay? So the other 55 I can't see. It was whisked away. I don't have it there anymore. Right? Otherwise my blood sugar would have gone to 1,000. If insulin wasn't
Working.
wasn't doing its job. So, and this
Like
is kind
you
of
see in type 1 diabetes.
like you see in type 1, exactly.
Yes,
And
okay.
type 1 diabetics have an
Don't
ins-
have any insulin.
They don't have any insulin, but
Right.
they also have an insulin to carbohydrate ratio. So when they're counting carbohydrates, this
Mm-hmm.
is their insulin sensitivity.
Okay.
So when they're counting their carbs, they go, okay, I know that for every unit of insulin, I can put away, say, 15 grams.
Okay.
You know, I would say that's pretty insensitive, but I would say probably more like for you and I.
I don't know anything about this.
Okay,
So you
so,
have,
yeah, this is a total.
I'm an 8th grader. I have no idea what's happening.
This is
So
like a pharmacist nerding out with you. Okay, but anyways, you have, so let's say for every 1 unit of insulin,
Uh-huh.
you can put away, say, 20 grams of carbs.
okay.
So for this particular meal or whatever, I would
Right.
only need 3 units.
Oh, I see. Okay.
Okay?
So your pancreas. So let's go to the type 2. So your pancreas is, putting that out there,
Mm-hmm.
and all of a sudden you only see 5 grams spiking
Right.
on your Freestyle Libre.
And the other 55,
have been dealt with because the
because I made
pancreas-
enough insulin.
Okay.
I made, for example, in this particular case, I made 3 units of insulin.
Okay.
Now imagine someone who is insulin resistant.
Mm-hmm.
They don't have that ratio. They don't need 3 units of insulin.
So they need.
They need 5,
Okay.
10.
Okay.
They need significantly more insulin for the same meal.
Okay.
But do we notice it? We don't notice any of it.
No.
And you may never become diabetic. And this is my point.
But that's why you need that Freestyle Libre, so you can watch the video of how you
Yes.
process the food once you eat it.
Right. But again, I'm seeing glucose. I'm not seeing insulin. So I think probably by far the most useful lab that you can draw, other than a lipid panel, because I think that's incredibly helpful, and we can talk about that in a minute, is a fasting insulin level.
Okay. And then those doctors don't do those.
Right. I want to hypothesize for hours about why don't we draw insulin levels. I mean, it's just, to me, it's just
But
total...
also, I think it's the same thing. It's a snapshot of just that moment.
Well, we
what
do
did you
fasting,
eat? What's
yeah.
going on? What's,
Right.
once
Right.
again, you need more of now you need the whole video. I like how you say that. You
Yeah.
want the whole picture
200
of what's happening from the time you eat it to the
Right.
time you're digesting it, what your well, not the insulin, but what the glucose is,
Right.
and then how your body's dealing with it.
Right.
It's kind of nice with the Freestyle Libre. Or what's the other one? The
Dexcom.
Dexcom.
Yeah.
Because
But you brought up like a really interesting point, because this is what we had the same issue with Chris. He had some oatmeal with some he had some cereal, some oatmeal,
Yeah.
hot oatmeal with some apples, and he went all the way up. I think he started at 100, went over 200, 250 or something like that, and then he finished pretty low in the 50s. So this is a really good example. Another symptom of too much insulin, which would be hypoglycemia, so low blood sugars after a meal, and you're hungry again, and you're low, because you had to release so much insulin. The one thing we don't see, that's only like little, oh, there it is, there's that little dude. That person's insulin had to go so high that it took so long for that insulin to finally be degraded by the liver and removed from circulation. But before it was degraded and eliminated, it was still lowering blood sugars to really, really low numbers into the 50s.
the insulin was still high.
Because the insulin was still high, and that's kind of a telltale way of seeing how much problem you have with insulin. But if you have symptoms of hypoglycemia, it's shaky, right? Like, oh my gosh, I'm super
And
hungry,
sweaty,
cravings.
yeah.
Your blood sugar is most likely really low because of that insulin resistance, right? Why don't we measure this? But I digress.
I don't know, the more reading I do, I'm like, why don't we?
It doesn't make sense. American Diabetes Association wants to cast a little bit of shadow of a doubt on insulin, which is, hey, we don't have guidelines that say that these are normal insulin levels. Like they could make a statement, but the reason they're not making a statement is that they can't agree on like what's the assay, what is the way
Right.
that we're going to measure insulin. They can't agree on it. You can't agree on it for some other reason. You're not telling us. Maybe it's something to do with, Dannon yogurt and other food companies supporting the American Diabetes Association
Well,
that don't want you to know what your insulin
It would be
levels
interesting who
are.
gives the money.
Yes.
Just
yes.
saying.
But I would recommend this to everybody. It's a cheap test. It's $25. It's so vitally important. Your doctor may not understand it. He may even balk at it. Just say, hey, I really need an insulin level. And then when you get it, give me a call. Because I will tell you, like, this is a good fasting insulin. This is okay. This is borderline not okay. Because I don't agree with, what they're going to say is normal. Just like I don't agree with the lipid panel. Two other symptoms of hyperinsulinemia is having high triglycerides and low HDL. That is definitely a poor man's way of kind of measuring how much insulin resistance that you have. So when you have high triglycerides and low HDL, and that ratio, when you take the triglyceride and divide it by the HDL, and that number's greater than, say, 1.9 or 1.8,
Okay.
then you have insulin resistance. That's a lot of people. It is
Okay, so-
incredibly common to see those type of lab values, not just in diabetics, but in everybody. When I go to the hospital, I look at HDL, down in the dumps, 30s, 20s, right? No one's talking about the fact that it's lit up like a Christmas tree, that you've got high triglyceride and low HDL. But this is where I'm also saying that our numbers, what we consider normal, is wrong. I think having a triglyceride level of less than 100 is ideal. And when you look at the lab, it's going to say 200 gets you a flag.
Now with triglycerides, it also deals with the liver.
Yeah, so in people with non-alcoholic liver disease, they're going to have high triglycerides.
High triglycerides. That's what I thought.
Insulin affects that disposal of those triglycerides. You can kind of think of it like this, is kind of very simplified, but if you're a carb burner, fats will accumulate. Triglycerides, which are fats circulating in the bloodstream, will accumulate. You're not using them for energy. If you're using those for energy, you'd be burning it like crazy. If you're using it for energy, your insulin level is going to be low. Okay, so you're now, insulin's doing its job at the fat cell, right, which is inhibiting fat breakdown, lipolysis.
Okay.
But also, insulin's working appropriately, and the insulin levels are low. So then you have the opposite of storage, burning. So this is metabolism, essentially. Metabolism is catabolism plus anabolism. What is the net change is what you are, right? The building, which is anabolism, and catabolism, which is breakdown. Insulin's in control of anabolism, which is to build. Glucagon, the opposite, or when insulin is low, is in charge of catabolism, which is breakdown, which is what you're familiar with. Autophagy.
Autophagy, right,
Yeah.
because of fasting.
Yeah, tell us about what. Yeah.
Yeah.
So you're a glucagon freak. I love it.
Well, not all. No, currently, no. Currently, I'm overeating, but well, that's another topic for another day. No, but my experience with fasting is that, especially, I'm really lucky. My husband and I do fasting,
Regularly.
together.
Yeah.
Not regularly right now, but we were doing it regularly. He did a 96-hour fast, which was amazing to me.
Yeah.
I was doing 48. I did do a 72. I do know that 48 seems to be my sweet spot.
Cool.
That I could fast for 48. I do listen to a lot of different doctors and about fasting. And first, before you fast, before anything, you need to be a fat burner. So meaning that you have to decrease your carbs.
Just to get into it
just
and make
to
it
get
easier.
in and
Otherwise,
do it for
what
a couple of
happened?
weeks. So if you don't, then fasting may be a nightmare because you're now, when you're a sugar burner, when you're using all sugar for energy, all of a sudden, after 24 hours, your sugar levels drop, your body gets shaky, you may get a headache, you don't
Keto
think,
flare.
you don't think right. Of course, we talked about before on another podcast, I think, about dumping salt
Right.
along with your
Sodium.
water. So then you have to add those electrolytes back. And things don't go right when you're fasting as a sugar burner. It's just,
Right.
you feel miserable for a couple of days. I don't recommend it.
Right.
From my own experience. So use
this-
from what I've done
Right.
before, because I tried both ways. And after 24 hours, I was like, I got to eat. I'm hangry, meaning
Yeah.
angry and hungry and crazy.
Right.
And it
So
just wasn't
cravings
working
are
out.
difficult.
Yeah. Especially
sure.
if you're a sugar burner. So if you're
Yeah.
eating a lot of carbs and that's how you live your life, fine.
Yeah.
And then, but I would take a couple of weeks, start decreasing if you want to fast, start decreasing your carbs to the point it's 20 or below. My husband is very religious about
So
that.
you're counting carbs. You're looking
now
at your
counting
labels.
carbs.
Right.
You're looking at all labels, and you want to eat whole food. Don't even
Non-processed.
look at
Excellent.
processed food at all.
Right.
And then, because then you'll get accurate amount
Yeah.
of how many carbs you're.
But
really
not to
intaking.
mention the massive ingredient list on some
Yeah,
of these.
anything more than 5,
Yeah.
I start to get.
Yeah.
am a major. I'll look at it and I'll go, oh, I'm gonna eat that. Okay, whatever. I just, sometimes you just gotta bite the bullet, because
Right.
life happens.
I gotcha.
But whole food is good. Count the carbs. Wait a couple weeks. Do this for a few weeks. Just start slowly getting the carbs out, and then after a couple of weeks. Then if you want to do small fasting, do like 12 hours, then do 16, then go to 24, and then jump to 48. And if you want to, 72. Lots of YouTubers out there
Yeah.
have lots of advice.
So who would you recommend to watch?
So,
Is there a funkster that comes to mind?
well, Jason.
Jason Fung.
But I also read a book called Fast Like a Girl.
Oh.
And it's
I'll not read that.
it's for women because it's Fast Like a Girl.
Who's that? Is that Megan Ramos?
No, it's Peltz.
Oh.
She's
no.
I think she's a chiropractor.
Oh, that's cool.
Yeah, no, she wrote several books, but Fast Like a Girl, if you want to read, if you're a woman,
Or Life in the
it's
Fast
really,
Lane, Jason Fung.
yeah. Oh yeah, Jason Fung. I just love him. I've read all of his books. I do a lot of listening, so I go on Audible.
Yeah.
Another one, he's super technical. We were just talking about him today, Dr. Attia.
Yeah.
Very technical, but a lot of them say count your carbs, decrease,
Right.
Anyway.
Otherwise, hunger will be a problem.
Yeah.
Absolutely. I had a new patient recently, A1C 11, now 6. But anyways, the one thing he said changed and that he was surprised the most about was the fact that he wasn't hungry. And in just a very short period of time, lost some weight, feeling healthier, sleeping, all the thing that I would say, just across the board, every single patient says, hey, I'm surprised about how I'm not hungry, more energy, I sleep better, they just feel better. It's just when you're fueling the body. Good. So get those fat cells to shrink.
So in order to help with insulin resistance, we have to start looking at diet. And that's kind of what we were trying to say with going into the fasting thing. It's just with insulin-resistant type 2 diabetes, start looking at how many carbs you're taking in.
Right, because we want to lower insulin.
And
no matter what.
You said A1C a minute ago, so
Yeah.
that test will, explain what that is. Because that's a good lab test if you're
but it doesn't
having
always
problems with
reflect your
glucose.
insulin level. That's the
No,
part.
but we
So
don't have a test for that, right?
I know.
Yeah.
Well, we have a poor man's test. We can measure triglycerides and HDL ratios, which would tell you. I mean, that's a little way around. We get your insurance to pay for your annual lipid profile.
But if your ANC's high, then you can actually have your insurance pay for your glucose
all kinds of
monitors.
stuff.
Right, exactly.
For sure.
So the ANC test is
Right. A1C is basically it's like glucose attaches to proteins and it glycates, and so that's where you get that hemoglobin A1C, the glycosylated A1C, which basically measures kind of like the scratches or like the little marks on a red blood cell. And the red blood cells last about 3 months.
120
In most people,
days. That's a life.
3 to 4 months. Some people maybe longer, if you think about that. So they would have more scratches. So they may have a higher A1C because their red blood cells tend to stick around longer. I don't know, maybe I'm one of those. Because I know my insulin level is super low.
Well, that's because you don't need carbs.
I don't need carbs, but also we were talking about low insulin lifestyle, like what that is really what it's all about. I want my insulin levels low. I want that autophagy. I want that almost fasting like.
So let's
thing
talk
to
about
go.
autophagy because we brought it up, and I don't know if people understand what autophagy
Right.
is.
I think of it as very simply is cleaning out like a little 5-year-old's room because they got toys and garbage everywhere. Cells need to be repaired. You need to get rid of that excess fat. You need to, mobilize that out of the cell. Let it shrink. Let cellular components be replaced, like the mitochondria, right? Because you can also this correlation between insulin and autophagy really correlates to lengthening of our telomeres, which essentially is how old are you, right? If you have high insulin levels all the time and you don't fast and you don't have good insulin sensitivity, insulin resistance, lifespan or health span's going to be reduced.
Okay, so I don't know if a lot of people know.
You
about
know telomeres better than I would have.
Well, no, I mean, telomeres
Cellular
actually, so telomeres, as they shrink, that's what your lifespan is. It tells you how your body has these telomeres, and at the end of they get shorter and shorter
cell,
during your
right.
life in the cell. And then once they're a certain level, then things start to die. And so that kind of tells you where your lifespan is.
Right. So you want to lengthen
You want to
your
lengthen your telomeres.
Autophagy would help with that.
But you
a
don't
low
want them to
insulin
decrease.
lifestyle.
You just want them to stay. I mean, there's I've done some breeding where I don't know if they actually lengthen, they just stop degrading.
Okay. Kind of like muscle.
Yeah,
Muscle
they
tissue, you
just
wanna
stop
stop them.
degrading. But
All
that's
right.
from what I read on it for so long ago.
Do we want to talk about the different manifestations of insulin resistance?
Yeah, I think so. Oh, you want me to?
Gosh, these are, I guess if you're sitting at home and you want to know if you have insulin resistance, we talked about waist circumference, we
Right.
talked about triglycerides and HDL.
Yes.
We talked about glucose levels if those are elevated. We should
Mm-hmm.
talk about high blood pressure. Hypertension.
Yeah, definitely
very,
hypertension.
Yeah.
Because a lot of people who have diabetes have hypertension. It seems
or
to
cardiovascular
yeah.
disease. They're all very much related. So insulin's effect on the kidneys is to essentially hold on to sodium and hold on to water, because sodium and water kind of follow each other through a particular system. Increases aldosterone through the RAAS system. But anyways, insulin does stimulate fluid retention, which causes high blood pressure. So you can do the DASH diet, dietary approaches to stop hypertension, or
So
you could
DASH
do
stands for?
dietary approaches to stop hypertension. So,
Oh,
which is
God.
basically, all it is a bunch of colorful vegetables. It makes for
Oh,
really
okay.
pretty graphics
Oh.
because it's low in sodium.
Okay, so low in sodium, that's really what a DASH is.
The DASH
Okay.
is, yeah. Oh, don't put salt. Listen, it isn't the salt. Your blood pressure will go up when you eat a bunch of salt, of course, but it's transient. It's going to go up for a period of time. You get puffy, you end up peeing it off, typically the next day or whatever. Eventually it comes
For people
off.
who have really high blood pressure, that's probably not a good idea that they eat a lot of salt.
I-
And I'm just saying, because 200
Yeah.
over 100, I don't want
Yeah,
to
if
send
you're
people to the
crazy
ER
high,
because they're
for
putting
sure.
a ton of salt on things. Okay.
But I would say, hey, look at your diet. If you have a diet that spikes your insulin, glucose, whatever,
Mm-hmm.
right? If it makes that go up, it's causing hypertension all on its own. Change the food, change the problem. I'm not saying that salt's the problem. I'm
Right.
saying carbohydrates and anything that spikes insulin is the problem.
Yes.
So
Okay, I get
hypertension.
that.
But that's crazy common. And that's what irritates me is that people think, I'm just getting older. And I need 3 different blood pressure meds. Typically, on average, 3. Like, you don't need this if you change your diet. Are you willing to make the lifestyle change to get off the medication?
Well, I mean, and that's, okay, so especially with the lifestyle changes, people go to have their gastric bypasses and stuff like that. I know. It's going to be all right. But I mean, what's the
Yes.
doctor's goal? Is to get them off the drugs. And what's the main goal of having a bypass is decreasing the weight, So
I disagree with the first statement. I don't think the doctor's
I-
goal
I-
is to get you off the medication. I kind of think that he's...
so I live in a very happy land. So I want the doctors
Yes.
to be like that.
Yeah, I know, but I think he'd be nothing without the prescription pad.
Oh,
Gotta write for the meds, right?
I guess.
But I'm saying that the
See,
medications...
I want a prevention society rather than.
Yeah, for sure. I want chronic disease reversal
Yes.
through lifestyle modification, not like what I did in pharmacy school and this condition, this drug, right? And here's all these different drugs for this condition, hypertension, and there's a huge list, and follow these guidelines, and it never says what's the cause, what's the etiology of hypertension. As you get older, it's not supposed to be higher. Your blood pressure should go down.
Yes.
And if you don't change your diet, it's never going to happen. But I would also say, as a caveat to everything we're talking about, is hey, you need to be under your doctor's care.
Yes.
You should be monitoring yourself because it's all about data. Data and how you respond to whatever thing that you're doing, whether it's lifestyle modification or removing medications, should be done under supervision.
Oh, absolutely.
You need to know what you're doing.
Yeah.
Right?
'Cause-
Just like you're talking about fasting, and hey, if you're on insulin, this is not a good idea.
No, it's not a good idea.
Right, right.
No.
Yeah, okay, so did we talk about PCOS?
No, we haven't, because that is a big topic, especially for a lot of women who have PCOS, is polycystic ovary
Right,
syndrome.
syndrome, right.
So, and I
have-
have never had it.
Okay, you're good.
Yeah.
Lucky you.
No.
Yeah, but to me, I could walk into the grocery stores. I can walk in anywhere and go, oh man, I really want to talk to her and tell her what she could do. Just a minor change in someone's diet
So
and how you can reverse
What
that so
makes you
easily.
think that woman has PCOS?
Childbearing years,
Okay.
acne, facial hair, male-like pattern
Surprising,
baldness.
I never had that. Okay.
Yeah, male-like pattern baldness, right? Something loses their hair.
Oh, interesting.
Yeah. They may have acanthosis nigricans, they have darkness in the creases of their neck. I see that in all different walks of races.
Right.
Whether African American, Hispanic,
Yeah, you can see the dark
Indian,
ring.
you can see the dark ring. So you know that they have hyperinsulinemia, right? And then the other part you would have to ask them questions, which is so really awkward for me. How's your periods? Are they painful? Are they infrequent? Because that's what PCOS would be. So the simplest way I can explain this is essentially is that you've got insulin resistance of the ovaries, and you've got too much androgens or like testosterone, like substances floating around, because every estrogen was once a testosterone. And insulin is what drives that conversion of testosterone to estrogen. But when you have insulin resistance, it doesn't happen. Your insulin level is too high, and that conversion doesn't happen from testosterone to estrogen. So estrogen levels are too low, and testosterone, like androgens, are too high. So you get more male features. Deepening of the voice. Yeah. Skin tags is another one.
Oh,
Little
yes,
little
skin
columns
tags.
of fat that kind of pops up. I got several of those back when I was heavier. Like you would have, they're benign, but what they are little fat columns that, under the influence of insulin, cause those fat cells to grow more than normal, right?
And so you get skin tags.
So you get skin tags. So skin tags is another symptom of insulin resistance and metabolic syndrome. What else? What else is left? What haven't we talked about? Alzheimer's disease.
Yeah, that's a biggie. But
And dementia.
yeah, who wrote? Okay, so what's her name? She's big on it.
Amy Berger.
Amy Berger.
Yeah.
Yeah.
Excellent book.
I should know her
Yeah.
by now because I watch her all the time.
Yeah. So basically, what we're calling Alzheimer's disease type 3 diabetes.
Yeah.
In other words, the brain is insulin resistant now. So instead of it getting, so you have two different. If we just back up, there's hyperinsulinemia, right? So this is the commonality, hyperinsulinemia with all these conditions, and then we have a blunting response, so the body doesn't respond like it normally would to insulin, and then there's a hyper response.
Okay.
So you have too much of a response. Okay. So in the case of Alzheimer's disease, the glucose isn't getting into the brain to feed the brain the energy that it wants. And this is where, like, the brain, the last organ that goes down, is going to sacrifice anything and everything to keep glucose levels the way it wants it. That's a hungry glucose brain. And what I'm saying is that if you think about this, you could make this brain, instead of being primarily glucose burner, but rather make it a fat or a ketone burner. We know that insulin resistance on autopsy is like almost every single patient has insulin resistance.
That has Alzheimer's?
That has Alzheimer's. But they never develop ketone resistance. The brain could have done just fine burning fat for energy, or ketones essentially, for energy. So take the brain and say, hey, I'm in control here. You are now, I'm going to feed you something different. I'm going to feed you ketones for energy. Because otherwise the brain will sacrifice muscle tissue and convert that to glucose to keep it going. The last organ to go down, right? And we don't find any ketone resistance. So you could have burned ketones instead and would have had a much better energy level. And the brain, this is the debate, how much ketones can the brain really utilize? And it's probably in the 70 to 80% range. It's still going to burn some glucose, but nothing like what we're doing today. Most people, their brain is burning like 80% of its energy as glucose. And that makes the brain such a hog for glucose that any time that glucose levels drop, and even if it's physiological normal levels, the brain is going to still say, I'm hungry, I want more. Get me more. Feed me, Seymour.
Oh my God.
I know. All right. I don't know if I want to talk about that. Let's see. All right. So how do we improve insulin resistance?
Yeah, that's. Improve it.
How do we improve insulin resistance? Because everyone has different levels of insulin resistance, right? So we talked about reducing carbohydrate intake.
Okay.
That's probably the biggest one. Okay? So to get insulin levels low, we want to reduce it coming into our mouth.
Oh, right.
We
So
also
you would just want to make a diet change.
a
Right?
dietary change. So diet's a big part of it. And then you've got rest and exercise
And sleep.
and sleep, right?
Sleep is big.
Sleep is huge. Sleep is a big part of this, right? So everybody does not get enough sleep. Literally.
No.
They think they can go on 5-6 hours and be just, which we did, which made me fat.
But I still do. That's my problem.
Oh, gosh, I can't imagine life
I
like
can't
that.
sleep.
Sleep is your superpower.
Yeah.
I know. That's going to be difficult. Because that is going to raise your cortisol level, which will raise glucose, which makes your body has to deal with that extra
I've
glucose. It
always
has to
not
make more
slept.
insulin.
I mean, it.
Yeah. That's difficult. But anyway, 7.5 to 8 hours of sleep. That's your superpower. Use it. Right?
Well, I'm lucky if I get
Cold room.
I get 6.
Right. Okay. Now what about exercise?
Yeah, I think. Well, I mean, they do
Of
talk
course, I'm a
about it
huge proponent.
constantly. Yeah,
Muscle
I
strength's
know.
a big part of that.
It
We
is.
talked about muscle strength
Well,
before in
even for-
Alzheimer's disease.
Yeah, and even with osteoporosis, you need some weight bearing.
Right.
So, you know.
Otherwise, the body would
Yeah.
deteriorate
Yes.
that bone tissue, right?
You need
So we
some
want to
weight-bearing
increase our
exercises.
muscle mass because that's our glucose sink. That's the reservoir. Okay, so we want to increase muscle size as much as you can. This is a genetic predetermined amount, right? You can't just go to the gym and I'm
Yeah,
going
you
to turn
can't
into Arnold
just
Schwarzenegger.
inject-
Right.
Inject testosterone.
Yes, exactly. So you have more places for glucose to go,
Uh-huh.
and then exercise pops the sensitivity of insulin. So now you don't need as much insulin, less Uber drivers, right? Less alarms, right? So now you don't need as much insulin. That's how you get your insulin levels super low, and you increase insulin sensitivity. You don't need as much insulin when you're doing this. Also, when you exercise, that mitochondria is able to deal with this ROS, this reactive oxygen species, is able to deal with basically its exhaust a whole lot better. You have to have some ROS. You have to have some inflammation. That's normal, that's healthy, right? However, it's important that you're able to deal with it properly. Exercise does that. I would also, as a caveat to everything that we said, seed oils
Oh,
are
yeah.
awful. I
They're
know we could talk
terrible.
about seed oils another time, talk about fats another time,
Yeah.
but that
But
does drive
yes.
insulin resistance, cardiovascular
What are
disease.
the, so the only oils that
inflammation.
are good are, I think they said avocado and olive.
Coconut and olive.
And
Olive at a
coconut.
normal
Yeah.
room temperature.
Everything
Absolutely.
else, throw in the garbage.
Right.
Because
right.
they cause a lot of damage you do not want.
Right. So it's not about calories. It's not about, hey, I'm burning this, I need to keep track of this.
Well, I mean, there's
Calories is
some-
a major distraction.
Yes, but there are some where you do have to count some calories. You can't just eat 3,000 calories and not
Right.
exercise. You're
Right.
gonna gain weight, no
Yeah.
matter what you eat.
Yeah,
Okay?
that is true.
All right.
That is true.
So
I
you
will
do
give
have
you
to
that.
count, you do have
But-
to count some calories.
But I would say satiety
Yeah.
is a big role in this. You will keep your calories in check if fat is the primary food source, especially animal. I just had to throw that in there.
No, I think that's important.
Satiety
because
with
people are
fat
afraid
is
to
huge.
eat
Carbs
animal.
don't make you satisfied. You can overeat carbs all day long.
Oh, yeah.
If you're going to go, oh, I'm going to only eat so many carbs, why are you eating the carbs?
No, I can eat a full, huge bag of potato chips. Not even a problem. I can whip those down.
Right, because it doesn't ever, you don't feel full.
Yeah, I don't.
But if you had some fat
Right.
with that, you'd be, okay, I'm done.
Yeah.
Right, the satiety index. So just like my new patient says, hey, I'm surprised with how hungry I'm not. So I think that living a low insulin lifestyle is probably, in my opinion, the easiest thing to manage. I don't have hunger. I don't have energy spikes. I feel good. I'm able to do what I want to do, right? I'm able
I
to
think
stay
that's
active.
a big thing, especially with people. I mean,
Yeah.
a lot of them are like dragging to get up, going
Yeah.
to work, going home.
Low energy.
Mhm.
And
Very low.
I would say to anyone who's considering this, you'll see a change in your energy level pretty quickly. It
Yeah,
is
and
worth giving it a shot.
Also, clarity in memory.
Oh, memory
Those are
function.
huge.
Cognitive function
cognitive
always
is-
improves.
It's my memory, I'm like on it. I
Yeah.
can do several tasks in my head, like, and line things up that I have to do, and then just do them
Right.
and multitask.
Yeah, it is amazing how much more
Yeah.
that you can handle mentally as well. So yeah, I would say it's worth a shot. I would do it under the care of a physician.
Yes. Always, everything is under,
Right.
go talk to your doctor, say, hey, I'm gonna try this
Right.
is what I'm doing, or have that conversation, even though some doctors are okay, not okay. Just have a conversation. I think it's well worth,
I'd agree.
you
Yeah.
gotta try it and see
Excellent.
what happens, like the next day.
Yeah, try it for yourself.
Yeah.
Do your N of 1 experiment.
Yes.
All right. Well, thank you for having, thanks Lenora for
Yeah.
for
Thanks,
being here
Kyle.
for the podcast. It
It's
was
always
fun.
good. I learned so much.
Do you?
Yeah, because
Ah.
this is out of my, I mean, I'm a chemotherapy.
I'm glad you're getting it.
Chemo-off
It's cool.
nurse. This is not my world.
Well, that's what I love to do. I
Yeah.
love to teach,
Yeah,
and
no,
I'll
this
teach
is
anybody
great.
that I can trap into a
Yeah.
chair or a hallway or anything. Anyways, all right, we'll
right.
catch you next time.
Thank you.
Bye.
You've been listening to the Unscripted Pharmacist Podcast with Kyle Rootsaert and Lenora Casey. Please like our program by clicking on the thumbs up button. If you have a question, comment, or suggestion, please jot us a note in the comment section. And be sure to subscribe to the Unscripted Pharmacist Podcast. Produced by Chris Stevenson, recorded at the studios of Calaveras.